I'm Dr. Victoria, and this is George.
Today, we are going to talk about urinary tract infections. For the past week, George has been having some discomfort when he urinates, and it has progressed to where he has a burning sensation, and today he even noticed a little bit of pink in his urine, which has been making him very nervous indeed. What is happening to George is that his urethra has been colonized by surrounding bacteria, likely from fecal flora. As this bacteria migrates along the urethra, it causes an infection. If it stops at the bladder, we call this cystitis. If the bacteria travels to the kidneys, we call this pyelonephritis. Infection can also occur at the kidneys if there is a systemic infection. Bacteremia can lead to pyelonephritis also. The culprits for urinary tract infections are most commonly E. coli, followed by Enterobacteriaceae, Klebsiella, or Proteus. Other bacterial sources of infection include Pseudomonas, Enterococci, and Staphylococci. As we continue to treat these organisms with antibiotics, more and more resistance occurs, and if an individual has a recurring urinary tract infection and has been treated multiple times with antibiotics, they are at risk for having a resistant organism. The lower urinary tract infection is cystitis, while the upper urinary tract infection is pyelonephritis. We can have both uncomplicated and complicated versions of these illnesses. Cystitis would include dysuria, urinary frequency, urgency, suprapubic pain, and hematuria. Pyelonephritis may or may not include all of the same symptoms, as well as a few other systemic signs, such as fever, chills, rigors, fatigue, malaise, back pain, as well as possible gastrointestinal symptoms, including nausea, vomiting, anorexia, and abdominal pain, both in the epigastric and lower abdominal regions. As well, prostatitis would have recurring cystitis symptoms, as well as pelvic or perineal pain. A special group to look at is our geriatric population. They may have general signs or symptoms of infection, but it may not be easy to localize the infection to the urinary tract. These patients may have an altered mental status when they have a urinary tract infection. For children, it is often difficult to distinguish cystitis from pyelonephritis, especially when they are less than 2 years of age. Pyelonephritis is usually accompanied by fever, but not always. Female infants are 2 to 4 times more likely to get a urinary tract infection than males, and uncircumcised males have a higher risk of developing a urinary tract infection than circumcised males. Urinary tract infections are common in childhood, and upper urinary tract infections are particularly notable because in the long term, they can lead to renal scarring, hypertension, and end-stage kidney disease. What makes an infection complicated or not complicated includes several things. Non-complicated infections are usually in immunocompetent patients. They have no comorbidities, they have no known urologic abnormalities, they are not pregnant, and they are premenopausal. Complicated patients would include immunocompromised patients, perhaps even a renal transplant patient, patients with comorbidities such as diabetes, and possible urologic abnormalities, including strictures, stents, nephrolithiasis. They may be pre-adolescent, postmenopausal, or pregnant. When we do a physical exam on these patients, for cystitis, they may have abdominal or suprapubic tenderness. It may be necessary to do a pelvic exam on females to examine for possible pelvic inflammatory disease. For pyelonephritis, you will find costovertebral angle tenderness. For prostatitis, because of that pelvic and perineal pain, a digital rectal exam may be necessary to evaluate for tenderness of the prostate. Laboratory analysis may not be necessary for uncomplicated cystitis, but if we suspect that the patient may have a more severe disease, further examinations will be needed. We will need a urinalysis, urine culture, blood cultures, pregnancy test, a CBC, and a CMP. The presence of leukocytes, nitrites, and ketones in the urinalysis would help us to determine if there is indeed an infection present. If we see white cell casts, this would suggest a renal origin of infection. Blood cultures and a CBC would tell us if there is sepsis or severe illness, and the CMP will help us to assess renal function. We do renal imaging for severely ill patients, patients with symptoms refractory to treatment, and the suspicion of any kind of urinary tract obstruction or renal abnormality, perhaps a calculus, obstruction, or renal abscess formation. We do a CT without contrast to show calculi, gas-forming infection, hemorrhage, obstruction, and abscesses. Contrast is needed to demonstrate renal perfusion. If it is not appropriate to do a CT in the patient due to a contraindication, we can perform a renal ultrasound. For acute uncomplicated cystitis, our first-line medications include fosfomycin, nitrofurantoin, and Bactrim. Second-line medications include ciprofloxacin. Pseudomonas coverage will require IV antibiotics such as a carbapenem, imipenem, meropenem, or doripenem. If we need to cover MRSA, this will include vancomycin, daptomycin, and linezolid. For pyelonephritis, outpatient antibiotics include ciprofloxacin, levofloxacin, or Bactrim. Inpatient treatment will require IV antibiotics of ciprofloxacin, levofloxacin, ceftriaxone, or aminoglycosides. As these patients are ready to leave the hospital, they will require step-down therapy to one of the oral outpatient antibiotics. It may be helpful to check your local antibiogram. This shows local resistance to antibiotics and may help guide your antibiotic selection depending on what region you live in. For George, we did a urinalysis and his results are still pending for the culture, but we can start him on some antibiotics now. He will take his antibiotics for the full duration of his prescription. He knows to take the prescription for the full prescribed time so that he can help prevent the development of bacterial resistance by killing off the bacteria in one go. Just because he feels better doesn't mean that all the bacteria has been killed off. Thank you for joining me today, my healthcare team. I know George will be feeling better soon once he finishes his round of antibiotics. Urinary tract infections are a common source of discomfort for patients, and they will vary in their severity. I am so thankful that we get to bring them some relief. I hope you will join us next time to see what George gets up to next. Bye-bye!